Hello?
Yes, sir, we can hear you.
Okay, you can hear me.
Yeah.
Okay, so I'll sort of share my screen. Can you just hang on, please?
Yeah, we'll start shortly after like 5 minutes. So,
You need to. It's saying a host disable participant screen sharing.
sure.
You need to give me the rights to share.
So you can share your screen now.
Yeah, can you see my slide?
Yes, sir.
So, can you tell me a little bit about your this organization?
Sure, sir. We are running a basically platform where all the dental students, dental auxiliaries are under one platform so that they can gain knowledge and they can learn about modern dentistry. Today, we
So,
have participants from first year to fourth year and some doctors. Plus, we have international contestants too.
okay, so this is a platform which was created in Pakistan or somewhere else.
Basically, it's the platform about international dentistry, but it has its roots in Pakistan. So we have started from Pakistan, but now we have our associations in Palestine. We have some country heads in India and Ghana, South Africa.
Okay, and where you a graduate from?
I'm in KMDC, Karachi Medical and Dental College, Pakistan, Karachi.
Acha, okay, okay, that's good. So you can let me know whenever to start.
Yeah, I'll introduce you and then we'll start the webinar.
Sure. Well, I don't know if you're able to get a crowd for this lecture because Pakistan and New Zealand are playing a T20,
Maybe that's the reason why we have less number of contestants right now.
which is fine, which is okay.
We had registrations. I think they'll join later.
No problem. So how's everything at KMDC? Who's your operative restorative head?
Basically, the commissioner of Karachi is what leading
Really?
Karachi Medical and Dental College.
No. So who's your restorative head?
As in,
Like operative dentistry?
no,
No, I'm asking who's your operative department head?
operative department head. I think it's Dr. Shah Faisal or something.
Okay. Shah Faisal, I think he was an orthodontist. No?
We have some changes in Karachi Medical and Dental College faculty for right. Abhi is वक्त
Mm-hmm. Okay.
So we are starting it now. I and I from Association of International Dentistry would like to welcome you all in this international online webinar. Our today's topic is composite restoration and aesthetics. Among us, Dr. Umar Dawood is present who will conduct the lecture. He has done PhD in adhesive dentistry, MSc in oral sciences and biomaterials, plus MSc in dental materials. We are very honored by your presence, Dr. Umar. We welcome you on board with us. We are looking for future endeavors. We will have one our webinar and 30 minutes question and answer session. To all the participants, you can write your questions in the chat box during the webinar. We will forward them to Dr. Umar at the end of the session. Kindly do not open your mics between the lectures. Dr. Umar, it's over to you now. You can start your lecture.
Thank you very much, Dr. Nayab. Thank you very much, Association for International Dentistry, if I'm naming the platform right. It really interested me to the fact when you first contacted me for this lecture, and I was the reason why I got interested in delivering. It doesn't really matter how many people come in. The important part is that it looks like a good platform, and what you need to do is that you need to grow in this platform a little bit more, and try to conduct more activities. And the other important part was that you're targeting basically the undergraduates, and that's where there's a lot of clinical skill. A lot of people are emphasizing on the fact of postgraduate training and these small CPD workshops and continuing education workshops. I think it's very imperative. It's very important for all of us to look back in the undergrad school as to what exactly are we lacking in. And the other thing is that hopefully by 2-3 months we are creating a guideline for composite teaching in universities. So hopefully, inshallah, once I have it, I'll be more than happy to share those guidelines even at your platform. So thank you very much for the introduction. Yes, my name is Dr. Omar. I am a senior lecturer at International Medical University. I represent my university for the division of clinical dentistry, where I'm taking care of. Well, obviously, I have a bigger chunk to cover for dental materials, dental biomaterials, and of course, I also lead the dental biomaterials research cluster at International Medical University. So, obviously, if the young minds also have any questions regarding research, I'm more than happy to answer those questions also. So, in this brief outline, in this brief lecture, I will stick to the basics. I will stick to make people understand most of the stuff at the undergraduate level. And that's exactly what the initial plan was also. I live in the city of Kuala Lumpur, Malaysia, where International Medical University is. It's a very vibrant university. It's a great university where there is a very good combination of teaching, undergraduate. We have our postgraduate diplomas for people who are interested, and of course, there is very active research that is happening in IMU. That's unfortunately in most of the part of the world where we actually belong from, where their research really needs to come up. And if anyone now needs to excel, has to excel in good research too. So that's probably what I'm going to talk about a lot. The resin dentine hybrid layer. So I'm sure a lot of people who are there in this lecture are aware of what the resin dentine hybrid layer is. This scanning electron microscopic image, I took this image inside a scanning electron microscope, and I hope you're following my cursor on the screen. This is the all important hybrid layer. This is the hybrid layer, which is the link between your adhesive and the composite and to your natural tooth structure, which is supposed to be the weakest link also. It's a very weak link, and there are many things that are being done, and we've been trying to modify adhesives to make sure that this collagen structure, this hybrid layer structure, becomes more durable and there is more predictable bond durability. Uh, so that's what we're going to stick around with in our lecture. Those are our research clusters in IMU. Dental biomaterials, I'm leading that. Epidemiology, stem cells, and dental education. So anyone who is interested in doing research, they are more than welcome to contact us, and we are more than happy to entertain all those ideas, because research is a very integral part of the academic platform. It's not just the academic platform, even from a clinician's point of view, his understanding towards the clinical procedures that he's performing, where be it an operative procedure, be it just a bonding procedure, and even a surgical procedure. So everything comes evidence based, right? And what research really helps all of you to do is to make you into opinion makers also, right? When you publish a paper, you eventually are giving an opinion, and you're leaving a legacy behind for everyone to follow. So it is always a good strategy for more and more people to actually get into research and try to understand what the basics and the fundamentals are. Remember, doing research in operative composite or adhesive dentistry is not about going at a very high postgraduate level. When I say research, I'm talking about the basics and the fundamentals, and that's what research actually helps you. When I was doing my PhD, my PhD wasn't really enhancing my knowledge beyond what adhesive dentistry was, but it was actually taking me back towards the fundamentals of bonding, because my PhD was related to bonding. Anyways, so here we are. Let's just start with the basics. These are the two images again we took. On the left side, you can see this is the mineralized dentine. This is the dentine structure that ordinarily looks like. This has not been etched, and you cannot see anything except for the tubules. And the moment we etch it and make it into a demineralized dentine structure, there we go. We have a huge network of collagen structure. And when you're applying the adhesive, it's this collagen structure that you are supposed to deal with, and that is a pretty challenging part. All right, people talk about a lot of composite failures or adhesive failures because of the application, or because the operator didn't apply it well, or because he was using not a good bonding. It's also about what's really happening at the molecular structure. So you can see how the collagen fibers they look like. And as a clinician, when you're applying this adhesive bond, you're supposed to cover or envelope this entire collagen bed. So that really becomes a challenge. So let's just talk in briefly about normally what the adhesives are being used. The etch and rinse, or the total etch adhesives, you etch and bond, and then the self etch adhesives and the resin modified glass ionomers. So in the etch and rinse or the total etch, obviously there is the 3-step and the 2-step, and in the self etch we also have the 2-step or the 1-step. And in reality and in practicality, the 3-step etch and rinse adhesive still works out to be a very durable bond, in which the primer is coming separate over there. So the mechanisms of adhesion include wetting, that is the amount of adhesive that you make sure is placed onto the dentine structure. It's the interpenetration and the micromechanical interlocking of the adhesive, and the chemical bonding that is happening. I'm sure everybody knows what the contact angle is. The more the contact angle is, it goes beyond 90 degrees. The adhesive spreadability, or the adhesive is not going to spread at a very high contact angle. It's going to have a better spread and a better wetting at a contact angle which is less than 90 degrees. So that's the fundamental, that's the basic that everybody follows. And obviously, the substrate, the adhesive that you're applying on to the tooth surface has to be clean. There should be good wetting, intimate adaptation, good bonding, and good curing. Those are again the fundamentals. Those are the points that one needs to consider when he needs to have a good bonding onto the tooth structure, and a high critical surface energy. That the etching that you are performing, it produces a bit of roughness and the micromechanical attachment for the adhesive bond. So it's because of that roughness and because of the demineralization, the critical surface energy goes high, and eventually that promotes bonding more towards the tooth substrate. So the dental composites that you are using is a highly cross-linked polymeric material. It consists of amorphous silica glass crystalline fillers, organic resin filler particles, and sometimes short fibers. They're bonded to a matrix by the presence of coupling agents. The composites have really come far, starting from 1950s on to the nano hybrid composites, which are now being preferred for posterior composite filling materials, right? So, yeah. So the classification, I mean, like going briefly into the classification is based on the filler or the matrix that we are talking about, the megafill, macro, up till the nanofill, and that's where the microfill and the nanofill composites are now doing fantastically well for posterior composites for that matter. So based on the classification of fillers, we can also classify them as MIDI, mini hybrid, nano hybrid. So the MIDI hybrid is a mix of micro and MIDI fillers, and the mini hybrid is a mix of micro and mini fillers, and of course nano hybrid. In nano hybrid, you are completely taking the filler size to the nanoparticle size, right? So because of the nanoparticle size, there is a much more surface area that these fillers are going to now contribute inside the composite matrix, and it's going to basically reinforce the matrix resin, right? So it's going to improve the mechanical properties. uh, it will help in reducing the shrinkage, the polymerization shrinkage that is happening. The polymerization shrinkage is a huge problem, but we'll go ahead talking about few steps in reducing the polymerization shrinkage, how we can actually go about reducing it. But one of the ways is to have a good filler content inside the composite. It reduces water sorption and staining, and of course, it has a diagnostic sensitivity. They can also be radiopaque fillers. Composites, well, the important components, BIS GMA, uh, uh, some of the polymerization additives that we add inside the composites, like a UV stabilizer or a retarder or an accelerator. So I'm sure at the undergraduate level, everyone is aware of these components, in which the bisphenol glycidyl methacrylate, which is known as the Bowen's resin, is actually the core structure inside the matrix phase of the dental composite. So the all-important resin dentine hybrid layer. We talk about the resin dentine hybrid layer. So this hybrid layer is a combination. There we go. That's where it is. That's the hybrid layer. So you can see it's a combination of the tooth structure and the adhesive that you've applied. Okay, that's the adhesive, and that's the hybrid layer. Okay, and you can see that the resin tag has gone inside the dentinal tubule. Okay, so this is a side-on view that you are looking at. So that again is the adhesive. You've got the composite here. That's the adhesive, and that's the hybrid layer. That hybrid layer becomes a combination of collagen fibrils entangled with the adhesive bonding agent, and like I said, it's a combination of the tooth structure and the adhesive, and it is considered as the weakest link. Okay, consisting of a collagen network exposed by etching and embedded inside the adhesive resin. So you can see well how, just to let you know, this is a total etch and rinse specimen that we are looking at. We have etched the dentine structure, and that's how the hybrid layer actually looks like. So how does the hybrid layer actually behave? The hybrid layer, when you're creating the hybrid layer and when you're trying to bond the two structure, it is very important that what you are actually doing to the collagen fibers. So I've shown you a picture of a demineralized dentine where all the collagen fibers are now being exposed. So one of the basic fundamental mistakes that normally clinicians or any practitioner would do is that they sort of, after etching, over dry the dentine surface, and that exactly what happens when you over dry the dentine surface. You watch the etchant and then you're over drying it. So after over drying, it collapses the dentine structure, and that's not what you want. You don't want a collapsing dentine structure, because you need a collagen structure which is very hydrated. You need a collagen structure which is like, you can see it's in a three-dimensional mode in this one, right? You can see, as compared to this one, the collagen structure is all flattened, it's dried, it's uh, it's become thinner. But over here, the collagen structure, it appears more hydrated. The collagen structure appears to have a more three-dimensional approach. So we want that because why? Because the adhesive is supposed to entangle around these collagen fibers more efficiently in a hydrated condition. So there is a difference between keeping the collagen hydrated versus keeping the collagen structure wet. So we're not saying wet, we're saying hydrated. So the moment you dry off the water that you've used to etch the dentine surface after removing the etchant, make sure that the dentine appears a little bit glistening bright. Okay, it should not appear dry. People call it chalky white. That's like making it dry. The dentine should appear a little bit moist, because that's what you want. You want the collagen fibers to stay hydrated to receive the adhesive over there. So the adhesive should be hydrophilic. Ideally, it's a mix and match. It should have a hydrophobic part of the composite resin. Hydrophilic monomers in mesh. The hydrophilic part of the adhesive, it enmeshes with the moist dentine and collagen that I was just talking about, and the hydrophobic part then goes attaches itself to the composite resin. So that's the important bit. It is generally accepted, or was accepted, or is expected at a certain level, that you need to line underneath the composite structure. The most common liners that were predominantly used in the past were calcium hydroxide. Again, I don't know why people were using calcium hydroxide. It's an absolute no-no underneath dental composite. The zinc oxide eugenol should not be used. Then came the age of visible light glass ionomers. Okay, but again, the direction now is now completely against it. We are not looking at lining underneath the composite restorations anymore. So these, I would really encourage the students to look into these two papers by Professor Igor Blum at King's College, where they had argued with this fact that we do not need to line underneath dental composites at all, until and unless it's a requirement of it's a therapeutic requirement. Let's say we are leaving behind a very carious dentine structure, a dentine structure which is in which the clinician is not sure whether this is infected or affected. So in that scenario, if there is a therapeutic reason, yes, we can think about lining using a resin modified glass ionomer. But generally, if it's a normal cavity with a sound, healthy dentine structure, and even if it is deep, it is not required to place a lining underneath a dental composite. A polymerization contraction is a huge problem with the composite that you're using, and even the adhesive that you are using. Generally, it's considered to have a 65% conversion. Some of the manufacturers, they claim up to 90% of conversion of the dental composites. But no matter what the manufacturer is actually claiming, the polymerization shrinkage factor will always be there. And no matter how much nano filler particles that you're using, the polymerization shrinkage factor will always be there in a dental composite, because the curing light is primarily sometimes not really traversing inside, it's not really penetrating inside the composite structure. So all of these factors, they contribute towards the polymerization shrinkage problem. So I'm sure everyone is aware of the C factor, the configuration factor, which contributes towards the polymerization shrinkage. Uh, so if you have a composite structure that is placed, sorry, sorry, if you have a composite structure placed onto at one surface, that is uh, a direction towards having a C factor which is equal to 1, right? So it's a single wall. So that is why it is always encouraged to place a dental composite in an incremental fashion, wall per wall or surface by surface, to reduce or keep the C factor as less as possible. I mean, ideally, I know it's sometimes very clinically very difficult to pitch in a C factor, which is 1, but generally the practitioners, they hover around C factor 2, which again is acceptable to a certain extent, that you accommodate the wall and the floor of the cavity to place the composite structure. So you can see that if you are doing a proximal cavity, there are many surfaces involved. So that becomes a complicated picture in order to produce an ideal configuration factor. And so you got to keep everything in mind, whether we will talk about the snowplow technique later for the proximal restorations, but that's what you need to keep in mind, that how many surfaces a cavity has and how many gingival floor in the walls does the cavity have. Just an indication of how the many different patients can come in. Okay, so this is one patient that reports to us with a broken chip of composite over there, and then eventually you are providing composites can do wonders. I mean, like, it can replace the tooth structure in a fashion that you can hardly ever notice. But you can notice one thing, that we prefer to keep the diastema open over here for the very reason of aesthetics. I mean, like, we really didn't need to broaden out the tooth structure by putting a composite that's gonna, like, increase the mesodistal width of the tooth structure. So the better option was to make sure that the chip is restored, and then eventually the patient was referred for orthodontic treatment also. Some of the patients come with peg-shaped lateral incisors, and it obviously, again, composite becomes one of the very good opportunity to actually provide a good tooth morphology. I mean, like, a lot of people would suggest, especially the prosthodontist, would go ahead suggesting a crown. But I always have this understanding that in between a situation of a prosthodontic option versus a composite option, try your best to keep it as a composite option till the last, rather than just going for a crown structure immediately. So, the basic important aspect of a composite structure is the appearance, right? The reflection of light, the scatter of light, whether the light is going penetrating through the tooth structure or it's getting scattered. So there is amount of reflection over there. Light is reflected by the mineralized tissue, mainly the enamel rods and the extratubular dentine over there. A light can also enter the tooth tissue through the structures. So there's a lot of funny things happening over there. The composite that you are using on the tooth structure has a lot of grave implications also. Sometimes the composite can go horribly wrong because of the appearance, right? Because of the light, the scattering of the light. So that we're going to keep that thing in mind also while we are discussing. I took this image just to let the students know and understand that while you are applying the adhesive onto the tooth structure, you got to make sure that your micro brush is extremely saturated. All right, your micro brush is extremely saturated, so that you are applying uh, like generally it is referred to as that you need to apply 2 coats of adhesive, right? So those 2 coats should be you should make the dentine extremely wet when you're applying the adhesive onto the tooth structure. And there is a reason why. Here we go. This is I was trying to place my uh, single bond universal adhesive. I was using single bond universal adhesive. You can see how shiny the tooth structure appears. By the way, this is after polymerization. This is happening after polymerization. So that shiny appearance should appear when you are applying the adhesive. It is because you need to have lots of adhesive onto the tooth structure, because a majority of the solvent is being evaporated. Majority of the solvent you are actually taking away also, because when you apply the adhesive, you are putting a very gentle stream of air to remove the ethanol and the acetone solvent, right? So your main triad, or the main implication when you are performing this clinical step, is that the solvent should be lesser onto the tooth structure. So a major component is being trying to driven away from the tooth structure, right? So you need to apply lots of adhesive. So there are a lot of functional monomers, the organic resin matrix structure. It should penetrate inside the dentine structure. So there's lots and lots of adhesive onto your micro brush when you're applying onto the tooth structure. And the critical surface energy of the tooth structure, it plays a lot onto it, because if you are etching, and even if you're not etching the surface, the critical surface energy, it plays a lot, it has a huge role in actually imbibing the adhesive onto the tooth structure. uh, the better part of dentistry now, there are many types that are now available, are the bulk fill composites. Here, this is my sonic fill uh, sonic fill tube that we actually use to place the composite inside, the bulk fill composite inside, with a little bit of sonication. Okay, we're doing this with sonification. Why do we need the sonification? We need a little bit of agitation for the composite to go inside, is because sometimes the composite, it produces a bit of voids inside. All right, so you got to make sure that you don't have any void. A void in a composite is a complete disaster, by the way. uh, 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 Okay, someone's raising hand. I would prefer to answer the questions later because I cannot see anything on the screen except my PowerPoint slide. So, what is the bulk fill composite resin? Can place and cure up to 4 millimeter thickness, all right, without affecting the degree of conversion. So now please keep the bulk fill composites in your mind right now, because I'm going to share one of the procedures, clinical procedures that we have started using. We came up with this idea with a very good friend of mine, Dr. Hisham, and we published a paper on that. So we are trying to place the bulk fill composite in a different fashion compared to what the traditional manufacturer really tends to advise you in their manufacturing booklet. So a bulk fill composite usually takes up to a 4 millimeter thickness. You can place the bulk fill together at a 4 millimeter thickness width. There are many types of bulk fill composites. They are the base flow, flowable composites, and the full body composites. And one of the important things, like when I previously mentioned, was is when you're talking about the depth of the cavity. Okay, generally you should not place a lining underneath the dental composite. So it's very important, it's very imperative for you to, before you're actually placing the composite inside the tooth structure, is basically you need to understand what your cavity is. Uh, Looking at the tooth structure, you see a gaping hole in there. Oh, I think I need a composite over there. But again, hang on. What you need to do is you need to, once you've prepared the cavity, and to be honest, when I'm preparing a cavity, I don't have in my mind a preconceived notion that whether I should put an amalgam or whether I should put a composite, or even for that matter, a glass enema in a posterior restoration. So, I mean, so once you've prepared the cavity, you need to put down your instruments. You need to put down your instruments. You need to think what exactly is there in front of you. You need to see the depth of the cavity. You need to see the extension of the cavity. All right. The extension might just rule out an amalgam filling that needs to be done over there. So all these factors, and again, the choice of materials. I mean, is my cavity huge? Am I supposed to use a total etch adhesive? Am I supposed to use a self etch adhesive? um, I do understand at the university level, when the students are doing the composite restorations, they have this thing in mind. Oh, we have a total etch adhesive that is available inside our outpatient department, and that's exactly what I'm going to use. But that is not what the science of dental adhesion is. You need to basically make a choice of the right kind of adhesive that you are using, and we'll talk about those choices in a moment. So recently now there has been a great how should I say, there's been a great practice of doing selective etching, right? So you're using the self etch adhesive, or perhaps even the universal adhesive in restoring the composites. But with the self etch adhesive, you prefer to actually self etch the enamel surface. And for that matter, even in the universal adhesive, yeah, I mean, personally, I would prefer to use a universal adhesive, which is which comes with a technique that has a bit of selective etching on the enamel surface. By the way, I'm sure all the students know what a universal adhesive is. Universal adhesives, if we are not talking about the components at the moment, it can be used as both as a total etch or a self etch process protocol. So I would prefer to use a universal adhesive with a bit of selective etching. So here I am, I'm using the OptiBond. Again, you can see the amount of adhesive that I've placed onto the tooth structure. You can see the dentin structure. Now over here, there's another thing that you need to imply. You're putting the adhesive, but where are you putting the adhesive? Are you putting the adhesive on to a dentin structure, which is healthy? Are you placing the adhesive onto a dentine structure which has a little bit of affected dentine? Because obviously infected dentine is no choice over here, that you're not supposed to leave behind generally the infected dentine. So you can see the amount of healthy dentine that is left behind, and of course, like I mentioned, that there is no use of a lining placed underneath the dental composite. And this why not place a lining has got to do with the thermal properties of the composite that you are using versus the thermal properties of the enamel at the dentine structure. The coefficient of thermal expansion is under question over here. So the coefficient of thermal expansion of these thermal properties of dental composites nowadays, especially the ones that are being used with 3M. I'm no advocate of any material. Let me just clear that. I'm not promoting anything, but generally, I have found 3M dental composites have come up with really nice properties which are very close to the tooth structure. So placing the bulk fill composite obviously again is an art. Uh, Goes up to, like I said, it's up to a four millimeter thickness over there. And then of course you can use your instruments to maintain a very good morphology onto the tooth structure. But the most important bit, that normally when people are creating the morphology on the tooth structure, is when they forget the occlusal compass. Okay, we call this as the occlusal compass, radiating out from the fossa of the maxillary first molar, and then there's a protrusion, there's a laterotrusion, there's a lateral protrusion, and there's a lateral resurtrusion and a mediotrusion. So these are the different forces that are actually that are coming onto the composite. So obviously red should be taken with a little bit of caution over here. That's where the maximum number of that's the maximum amount of pressure that will come up over there. So you basically need to understand where the maximum pressure is coming onto your tooth structure to actually design your morphology. Any composite structure without a morphology, obviously now the patients are becoming more and more aware, and they require more and more aesthetic results. So you better look into that procedure while you're performing. These days, we also do the occlusal stamp technique to make sure that we provide the morphology of the tooth structure to the patient which he generally had. So for this tooth structure, what we're doing is that we are taking a specific rubber-based material that comes for the occlusal registration, and we place onto the tooth structure to get the impression of that occlusal surface. And when you're placing the last composite layer, you're just pushing on this registration or the occlusal stamp to get that anatomy onto onto the molar. But obviously, when it comes to the anterior tooth structure, I'm going to keep the time also over here in mind. When it comes to the anterior structure demands a lot of uh, a different attitude or a different protocol as compared to a posterior composite that you're performing. Uh, Everyone is aware of the developmental grooves on the anterior, and when you look at the anterior tooth structure, the anterior tooth structure has these different surfaces, these different uh, aesthetics compared to the posterior teeth. Each and every section that I've just pointed out, or I've just marked out, carries a different shade, carries a different, sometimes even the shape can differ in different incisors. So apart from the developmental grooves and all these surfaces onto the tooth structure, they appear, and so you got to make it as natural as possible over there. It's compared to the posterior, which is completely different. So marking onto the anterior teeth with the help of an indelible pencil to make sure that you make sure you prepare those developmental grooves while you are preparing the composite structure. You can use the gold brushes to polish them, and then have a tooth structure which is like, you can see that this part of the tooth structure, this part of the tooth structure, and this part of the tooth structure, it sort of indicates that there's a different level of shade, and the color appears different. There's a bit of translucency over here, a bit of translucency, and a bit of opaqueness over here. So that is the result of using the different kind of different shades of composite that you generally apply. A3B, the general shade guide for this one should was A3B towards A2B, and then preparing the clear translucent structure. We will talk about the translucent structure over there. Uh, the developmental grooves are very important. They give a very natural appearance to the enamel structure, and this palatal shelf is created with the help of a impression silicon. We prepare a silicon key. Okay, I'm just going to show you the silicon key in the next slide. So you can see that there's a difference over here. This palatal shelf that is first created, you can see that we have used an opaque dentine uh, shade composite to create these depressions over here, and then eventually these depressions, they are then eventually covered up with the dental composite. Uh, uh, Normally we are using a composite of grayish translucency over here, right? So this opaque dentine porcelain, sorry, dental composite, I'm sorry, is then eventually covered up on the edge with the translucent, a much more translucent shade, in order to provide, and then after covering up the enamel completely, let's have a look at the final let's just have a look at the final shade over here. So those depressions that were created onto the edge are very imperative, very important to give that aesthetic look onto the central incisors. And like I mentioned, we can use an indelible pencil to mark these developmental grooves onto the tooth structure, and then create a very fine tracer-like application of the handpiece onto the tooth structure. You can use a tapered fissure burr, and just make sure that you remove those pencil marks, and that should be more than enough to produce. So you're not creating a depression over there, by the way. You're just creating just a bit of undulation to give that aesthetic look. Uh, the undergraduate students should keep one very important point in their heads is when they are choosing the composite shade, right? Because of the presence of the property of metamerism, right? The shades, they appear different under under different light. Generally, the option that they suggest is to choose a composite underneath sunlight. Well, not the entire world is working next to a window, so obviously the shade it's a better option to make sure that you choose the shade by switching off your dental light, right? And you always have to make sure that there's a golden proportion onto your face, onto your facial structure, and you can see how the tooth structure is normally exposed when the patient is generally smiling. So you got to keep these horizontal and the vertical perpendicular lines uh, in consideration, and you can see that the central incisor has a much bigger box exposure as compared to the lateral incisor. So that obviously comes in mind when you're deciding the width of the anterior restoration that you're doing. These are the missing upper lateral incisors with a spaced anterior region, the central incisors and canine teeth are already approaching the limit of their width. Okay, so again here it becomes a choice of not completely closing the gap, because obviously closing the gap would increase the width. You have taken an impression by the help of the silicon key, the putty impression material that you can use, uh, and then you create a palatal shelf. All right, you're creating a palatal shelf. You're applying a very thin composite layer, generally an A3B shaded posterior. Uh, Maybe you can use a nanohybrid composite in this case also, and you can place a palatal shelf on the side. First create a palatal shelf and then start building onto the palatal shelf to create those layers and then bring about the whole tooth structure. So again, the translucency at the end of the incisal edge is extremely important. So the initial question that I had actually raised on to the floor, whether we should have a self edge, we should have a universal bond, or an etch and rinse for that particular case. Sorry, let me go back to the case again. This is a central incisor chip we are looking at, a healthy 21-year-old female presenting this chip. So the big question that comes in the mind is whether I should go for a self etch, whether I should go for universal bond or an etch and rinse. Uh, 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 all the three bonding agents can work well. That's a very safe point of view to take. All of the bonding agents can work well, but sometimes the bonding agents, they come up with personal preferences also. But when you relate to the tooth structure itself, when you're looking at the tooth, let's just talk about a cavity that has a dentine structure. Okay, over here you cannot see enough dentine structure in this particular case, but let's just talk about a posterior cavity that I just showed you previously. It has a dentine structure. So the more the dentine structure is involved, my preference would be to go to the etch and rinse technique. All right, because the etch and rinse technique involves an etching procedure in which I'm going to use that etching procedure to completely remove or demineralize the tooth structure to expose as much as collagen fibers, because dentine involves a lot of collagen fiber. So it's a general perception to keep it that way, to have a posterior deep cavity. But what is the disadvantage? The disadvantage would be that if I am demineralizing the tooth structure and if I am exposing the collagen structure, I am coming about making the patient more prone to postoperative sensitivity. All right, this is a very natural thing that should come up in every student's head. And I'm promoting total etch and rinse onto the dentine structure, but there's always an incidence of postoperative sensitivity. That's where the idea comes that you got to make sure that when you're applying the adhesive, you're agitating the adhesive onto the dentine structure, you're applying lots of adhesive onto the dentine structure to make sure that there is no disclosed or open dentinal tubules over there, and you're going to make sure that the spreadability of the adhesive is also good. So generally, when you are towards the dentine structure, you do incline towards the etch and rinse, and when you are onto the enamel structure, that's where the self etch and the universal bond comes in. Personally, I'm not a fan of the universal bond. Uh, I've got lots of problems with it. I mean, like we can discuss this sometime later. But the universal bond durability has been always been challenged by the durability coming from the H and rinse. All right. So, but again, the structure, when you're talking about the structure itself, when you're looking at more as more enamel structure, I would be more inclined towards using the self etch and the universal bond. A nanofill composite resin or the microhybrid composite resin can also be a good choice for the placement of dental composite onto the anterior structure. So uh, uh, one important thing is sorry, is the beveling of the tooth structure. When you are uh, putting a composite onto the anterior structure, you need to do a lot of bevel. All right, you're doing a bevel in order to create a tooth structure with composite that might just pass the bevel. Okay, the bevel is up till here. Okay, but I'm placing the composite a little bit beyond the bevel. That is primarily for the reason why, because the composites may produce, there should be the demarcation line of the composite should not be at the edge of the bevel line or at the edge of the cavity. It should be always be beyond, because of the because of the aesthetic reasons. Your composite should like slide inside the shade of the natural enamel. And of course, the beveling is done to increase the surface attachment of the dental composite. That's again goes to bond durability, right? So that's the silicon key, and that's the composite placement. And the moment you're placing the last composite layer onto the tooth structure, it's always is a good practice to make sure that you cover the last layer with a little bit of glycerine. All right, a glycerine or even an ultrasound gel can be a good option, because you got to take care of the oxygen inhibited layer. So the last layer, you cure it through the gel to make sure that you are avoiding the phenomena of oxygen, because the more the oxygen or the atmospheric thing acting onto the composite, the higher chances are for the polymerization to not happen close to 100%, right? So obviously composites comes when you're placing the interior composites, it comes with a lot of layering. You're not just using one composite onto the tooth structure. The inner core A3 Supreme Ultra A3 is generally the one that you consider placing in for the opaque dentine layer inside. And as you can see that you go more towards the lighter shades when you are towards the outer side, right? And the deep translucent one at the incisal edge, where you had created those depressions, because you want the light, because light is not reflecting here. You want the light to actually penetrate through the incisal edge to give you that natural translucency over there. Nowadays, it's always a good practice to just make sure that you are cleaning the tooth structure before bonding. Uh, uh, when I meant nowadays, what I meant is that using a prophylactic air abrasion has become sort of a common practice now, to make sure that you are removing the biofilm and you're cleaning off the tooth structure. And not just the biofilm, you are actually cleaning off a bit of the carious structure from the dentine also. And whenever you're placing the posterior composite, it always is the protocol is known as a successive build up technique. It's generally normally the technique that is followed, but I'm just a little bit wary about using the amount of composites in this technique. It's established technique though, but you have to make sure that, I mean, in my case, I would prefer to reduce the composite buildups, increase the composite buildups by increasing the number of layers, rather than just following what the standard is. That's the silicon key I was talking about. uh, so I want to get on to a very important aspect. Okay, let's just talk a little bit about the shade guide. The shade, that it always is a good practice to the students need to place the composite onto the tooth structure. You're not etching over here, you're not doing anything, you're not applying the adhesive. Just place the most probable composite next to the tooth structure and cure it for 10 seconds. Okay, just see how it goes. If it matches, then obviously you can use it, and you can just remove this after matching the shade over there. So it always is a good option to layer the composite. Okay, you start off by placing in the dentine opaque layer. So you go up and you create the depressions, and eventually you close off with a bit of grayish translucency over here. All right. So got to make sure that the developmental grooves are there. You've created those grooves. But one thing that normally the students, and I have had problems with the students of mine here at my university, where they've been making this critical error. It sounds very casual, but believe me, that's the critical error. When you're preparing a cavity for dental composite, any type of dental composite restoration that you're doing, like a central incisor or a molar, whatever you're doing, you got to be very, very careful as to what is your substrate like. I mean, is your substrate clean enough? Is your substrate, now let's just have a look at the gingival floor over here. Okay, let's have a look at the floor over here and just have a look at, is there any dark brownish line still present onto the tooth substrate over there? Because that dark brownish line, which you can feel it with your probe also, will eventually decide whether your composite is a failure or is it going to be a successful filling that you've done for the patient. Because that brownish part of the dentine which is there is a probable reason for failure. You got to make sure that your tooth substrate is as clean as possible, because the adhesive bonding requires an absolutely immaculate tooth structure. That is the reason why a carious tooth structure where you've done the bonding may have a lesser longevity as compared to a bonding that you have done on a healthy dentine structure. And as you can see also, in none of the tooth structures there is an application of the lining over there. So, as a clinician and even as a student, you need to understand the hierarchy of the tooth structure. Which part of the tooth structure is extremely important for you to retain? Which part of the tooth structure is something that is going to decide the longevity of the restoration. So, the secondary dentine and the tertiary dentine, they tend to have a very less reliability when you're placing in the composite structure onto the tooth. Well, uh, uh, normally in academic institutions and generally people, what they generally imply to students is that the current best approach is to place in a flowable composite. It's very popular, but scientifically, it has not been proven to be better. That you're first placing a flowable composite and then placing the composite structure. So the goal is to use as little flowable composite as possible. That should be the goal. But in my opinion, and if it warrants, and if you have the right composite tubes in your clinical practice, I think the best option is to actually go with even without the flowable composite, until and unless you are using a bulk fill composite, that becomes a completely different picture. There's a reason to use 2 millimeter increments, 2 millimeter increments in when you're talking about the conventional composite. But obviously, the bulk fill can go up to 4 millimeters, as I mentioned. And generally, the snow plow technique is also considered as a good technique where you place the flowable composite onto the gingival floor. You do not cure it, and then you place the conventional packable composite on top and then cure it together. That's considered as they do consider that, but again, I have a lot of reservations to that also. The recommendation for is generally is considered as a total edge technique, right? A total edge technique providing a good bond. But again, the total edge technique eventually goes on to a tooth substrate which has got more dentine structure onto the tooth substrate. Place and dry 2 coats. Make sure you air thin. And again, like I said, 2 coats of adhesive onto the tooth structure. Air thinning is primarily to remove as much as solvent from the adhesive before actually you are curing. So again, the big question arises whether to use total edge self etch or self etch with selective etch or universal adhesive, right? Because uh, the biggest problem is for the post-operative tooth sensitivity. The self-etch adhesive will try to maintain the smear layer over there. All right, maintaining the smear layer comes with a lot of problems, by the way. And the self-etch adhesive supposed to actually penetrate through the smear layer, right, and inside the dentine and so on. But the total etch has the function of using the etchant and completely removing the smear layer. So, well, at one stage, I'm saying that the total etch is more inclined towards when you have a good dentine structure, you can work well with the total edge, right? But total edge again comes with a lot of post-operative tooth sensitivity. It can come it comes with etching, right? So one thing that clinicians do not realize is when you are etching the tooth structure, you are eventually activating the MMPs inside the dentine structure. Now, what are MMPs? MMPs are the matrix metalloproteinase enzymes. All right. In fact, I've seen those enzymes under the microscope getting activated with the agent. I'll share the paper with the organizers later, and you can have a look. That the agent eventually activates the MMPs. So in a way, and what are the MMPs doing? The MMPs are the prime reasons for the degradation of the adhesive bond. They are the prime reasons for degrading the collagen structure within the hybrid layer. So in a way, it appears that, well, my filling has failed before it even started, because you have, so that those are the ways, and those are the reasons that you need to keep it in your mind while you're actually performing the two structure, right? The adhesion protocol over there. Self etch, well, it's not primarily removing the smear layer, so you are still playing around with the smear layer over there. So that has been a question that has been sought by different researchers, and more studies are coming on it. But at the end of the day, the fact lies with this idea that all three procedures can be successful, but if they are performed well, if they are done well. All right, and when I say done well, it is always a good practice to make sure that you're following the fundamentals, the basics that you're doing. And the most important bit is that most people, they do not realize is when they buy an adhesive bottle or a composite tube from the manufacturer, please make sure that you read the manufacturer's instructions. All right, it's always a good practice to read the manufacturer's instructions, and you can see the huge difference between the dentine structure here and the dentine structure here. The dentine structure over here is being created by the total etch. It's completely demineralizing the tooth structure, and it's exposing a lot of collagen over there. And this collagen is supposed to receive that adhesives, and this is a self-etch dentine structure. You can see the difference between the dentine being exposed in with either of the adhesives. The solvent inside the adhesives must be completely volatilized. It should be it should be evaporated. It's a gentle stream of air really helps to do, because the more let's say you're using a single bond universal that has ethanol inside, or let's say you are using the 3M total etch and rinse adhesive, right? Single bond system. Both are ethanol based adhesives. So if the ethanol stays inside the adhesive more, there are more chances for the collagen to shrink. All right. Okay. At one point of time, that shrinkage of collagen will help you. Why? Because let's go back to the picture. If the collagen shrinks, you can see these interfibrillar spaces. These interfibrillar spaces, they will increase. That's the role of a little bit of ethanol that you want to use with the adhesion. But you cannot have the entire ethanol curing inside. You want a bit of evaporated, because more ethanol will eventually lead to more shrinkage. If there's more shrinkage of collagen, then that's a problem we just discussed. So selective etch technique with universal bond, or selective etch with even with self etch is the way to go. There will always be an academic debate between clinical, the clinical debate and the academic debate between. I mean, what is truly the best adhesive? But if the fundamentals that I've just discussed in with all of you is probably that you need to. That's if now here's the point. If little dentine, if there is a bit of dentine over there for you, if you see a bit of dentine, your mind should eventually switch towards using the total edge. All right, I'm seeing a dentine here. You can see the dentine. So you see the amount of collagen structure that you have to handle in the dentine structure. All right, and then of course more, if you're more towards enamel, then you're going more towards using the self etch or the universal. So it removes the total etch, or the etchant removes the smear layer. There's a bit of problem of sensitivity, and it demineralizes the hydroxyapatite from the dentine and enamel. So according to the archives of oral biology, there was a paper that says that once all these structures are removed, they're never going to come back. Obviously, the demineralization factor. So you are eventually demineralizing, you're removing the hydroxyapatite, or sort of modifying the hydroxyapatite completely forever in that place. So total etch comes with a bit of post sensitivity problem. It demineralizes dentine to varying depths because of the etchant being used separately. The demineralization can happen at various depths inside. It opens a lot. It opens up the dentinal tubules, exposing the collagen. So when it's opening up the dental tubules, that's where the post-operative sensitivity issue happens. So it uh, with apart from that, once you remove the, when you're trying to remove the etchant, there is a lot of chances that you will end up having a bit of dryness or desiccation or excessive drying of the dentine, which again becomes a problem while you are bonding. The acidic component of self-etching system does not create enamel etch patterns or on intact enamel seen with traditional phosphoric composite. That's the biggest problem that is there with self-etch. It does not create those etching patterns that are required. Enamel prisms, I mean, like, enamel prisms, what they appear, or the hydroxyapatite, what it appears after etching, does not appear with the self-etching adhesives. So there are often cases of sclerotic dentine. People encounter a lot of cases with sclerotic dentine. So the recommendation to use, recommend to apply phosphoric acid to these affected dentine areas is for 15 seconds, and then you can actually use a self-etch adhesive on top, the self-etching system. So you can see this is the self-etch system that we have used. This was an image that we took for sclerotic dentine, and we could see that the resin tags had penetrated quite a lot inside. Generally, it becomes a problem while you are putting up onto the sclerotic dentine, the adhesive, the self-etch adhesive. So it has to come with a bit of phosphoric acid. So you can use a diamond burr also to abrade the tooth structure initially. Selective etch technique is perhaps a technique that is gaining up more and more, and more universal adhesives are now being used even in posterior composites with the selective etch technique, and it has come out really well as far as the results are concerned. I'm not going to talk about the components of the adhesives. I'm sure the students are well versed with it. Uh, so the solvents inside it's important to know what the solvents are doing inside. The ethanol is used to remove and replace the soluble water inside. All right, this is the moist edge dentine. You can see that the collagen fibers are hydrated, not just with a bit of water, but also with ethanol. So that little bit of ethanol that you require, it takes away the loosely bound water. It takes away the excess water. You don't want excess water here. You want just enough to keep the dentine hydrated as compared to the collapsed collagen, which is much more lower. So generally the ethanol wet bonding technique, causes a decrease in the diameter of the collagen fibers. I told you there's a decrease in the collagen fiber diameters, and because there is a increase in the hydrogen bonding between the collagen fibers. All right, so that allow the ethanol wet bonding tends to allow the penetration of the adhesive more as compared to if you're using an acetone based adhesive. So one of the techniques that I was talking about was the co-blend application technique. The co-blend application technique involves placing the bonding agent, okay, placing the bonding agent and placing a layer of bulk fill composite together and mixing it together and then curing it. Okay, I'll repeat again. In a co-blend technique, you apply the bonding agent, but you do not cure it directly. Then you apply about 2 millimeters or 3 millimeters of the bulk fill composite and mix them together and then cure it immediately. The reason why this appears, we've used, this is a dye that we were using to take a picture. Let me just, that's the red layer. I'm sorry, I covered it up with my markings. You can see that the adhesive and the bulk fill has combined together and we have cured it together to place it inside. That's the adhesion protocol that I'm also following now. Uh, uh, the adhesive can degrade, the interface or the hybrid layer can degrade because of many reasons. There's degradation of the adhesive resin, degradation of the collagen fibers. MMPs play a vital role, and biofilm and caries. So because of all these factors, now we need to look into the performance of the adhesive. We need to make sure that if, let's say, there is degradation of the collagen structure, what am I going to do to prevent that degradation of the collagen structure? Here's a look at the collagen structure. This is how a collagen structure looks like at 100 nanometer level. Can you see? I'm sure all of you can see these bands. If you see this dark and white bands, black bands and white bands, alternating bands, it means it's a healthy collagen structure inside the dentine. All right, and that's the collagen structure that is supposed to envelope the adhesive around it. And but we have got to make sure that, hang on, we're going to make sure that this collagen structure does not degrade. We got to make sure that it does not degrade. So we have come up with a new material called it's an antimicrobial 2% K21 QoS. Well, my associates and my friends who I've collaborated and worked with to produce this material, we're calling it a game changer. We're calling it a game changer for a particular reason, because before bonding, before bonding, we apply the we apply the etchant. Okay, so now I'm letting you know the procedure how to use this K21 antimicrobial before the bonding. Okay, because this uh, okay, we're going to talk about the benefits later. First, let's just talk about how it's going to work. So we etch the tooth structure. We, after etching, we wash it off, and then we apply this 2% K21 antimicrobial on the dentine structure. So you can have a look at over here. So this 2%, that's the dentinal tubule. Okay, you can see this 2% K21 material it condenses on the dentine structure. Because I don't want to get into the chemistry of the structure. You can I'm going to let you know the paper if you want to read that paper. This structure condenses on the dentine structure the moment you apply on the dentine structure. Because what happens is it is partially condensed. But when you apply on the dentine structure, it fully condenses. So now after etching, now you have a crusty layer on the dentine structure that you are working with. Sometimes this layer can cover the dentinal tubules also. I can understand. And then you apply the adhesive. Now that's a funny thing. It's something really opposite to what we have been initially doing with bonding. We need a completely clean structure. But no, what we have done is we have applied the adhesive, and the adhesive tends to penetrate through the tubules, and it tends to dissolve this on top. So there is no problem of the penetration. Have a look at this. You can read this paper later on, and you can see that the resin tags have been formed. So this 2% K21 antimicrobial gets pushed inside the dentinal tubule like this. So we did a confocal microscopy. We stained the 2% K21 material, and this K21 was now seen inside the tubules, the green stuff that you see on the confocal image. So the adhesive is pushing that inside. So the question arises, why do I need this antimicrobial? This is something against the bonding procedure. We need this K21 inside. We need this antimicrobial because it's a compound that is quaternary ammonium based. It's an anti-MMP. It's an antibacterial. So that does my job. So sorry. So we're leaving behind an antimicrobial that's going to take care of the secondary caries because it's right there on the surface. Here we go. I'm just going to show this surface to you in detail again. See, it's right here. And there's a lot of antimicrobial that is going inside the tubule also, right here. So the MMPs inside, the MMPs, they start getting deactivated inside the dentine. So this strategy was applied to make sure that we increase the bond durability. We make sure that we provide the protection of the hybrid layer. All right, so you can see those the K21 has condensed into. So why has this condensed into this sphere shape? Because it came in contact with the moist dentine. The dentine, it took up the water, the moisture from the dentine, it condensed fully inside the tubule. So it became, so that's the paper. You guys can take a screenshot, and if nobody can download, just message me. I'll send the paper to all of you. So you will understand that's the fundamental process of adhesive bonding that we are trying to change here. So that's the those are the kind of cavities perhaps I will be planning to use more and more of this cavity disinfectant onto the to structure. Well, Stephen Hawking has always been an inspiration. There is no aspect of reality beyond the reach of the human mind. So you can think of a lot of things to do. You can think of a lot of things to do like this. In this particular strategy of bonding, what we did was we used an ultrasound energy. We used an ultrasound energy known as the high intensity focused ultrasound. I'm sure this gets a little bit heavy for the undergraduate students, but just follow me over here, what I'm trying to tell you. Now see the difference between this picture and this picture. In this particular picture, you can see a very well-defined hybrid layer. In this picture, you cannot see a hybrid layer. You can see this picture also. There's no hybrid layer here. We've not created the hybrid layer. So the hybrid layer, either through universal bond or the total edge, well, this was a total edge specimen. So we use the etchant, we put the bonding agent, then the composite and all, and then we create the hybrid layer. But not over here. We did not create a hybrid layer, but we still had a good bond. What did we do? We used an ultrasound energy to remove the hydroxyapatite from the dentine structure, expose the collagen fibers, and then apply the bonding agent. So the bonding agent directly went on and attached itself to the intertubular and the peritubular dentinal structure and the collagen without creating the hybrid layer. So what was the idea? The idea was that the hybrid layer, like I said, is the weakest link, is creating a lot of problems. So with this strategy, we did two things. We took out the etching procedure completely while using the total etch. The total etch cannot be done without an etchant. So we took out the etchant completely, so that problem of activating the MMPs goes away. And we have taken out the hybrid layer from the equation completely. So that's how we are going to challenge the degradation factor. No hybrid layer, no degradation problems. So we trying to increase the longevity of the tooth structure. But again, yes, there are claims being made, but eventually there's more work needs to be done. We are still studying this, whatever interface this is, where you can see only the hybrid, where you can see the resin tag going in, but we are still studying this interface in much more detail, and hopefully we will come out with much more. So I would like to thank everyone for joining in this lecture. I think I've taken in a little bit more time as what was suggested to me, but thank you very much to the Association of International Dentistry, Dr. Nayak. Thank you very much, and whoever has contacted me for this, and I'm open to questions.
Yes, sir. We'll ask you a few questions as we are running out of time. There is a question sent by one contestant. Is it necessary to apply dentine bonding agent after the composite restoration is done, as it is being practiced clinically?
Yeah, you mean to say in between the composite layers?
Yeah.
I assume the question is, yes, it is a common practice to place the adhesive layer in between the composite layer. They think for a better attachment. Uh, but let me just go back to my initial example before I answer you that. Composites do not require underneath composites. First, I'm talking about underneath composites. Underneath composites, there should be no lining at all. Okay, because of the fact that composite works best without any interfaces. Composite needs to be directly attached onto the tooth substrate. Similarly, this is a myth that was created, unfortunately, by the clinicians, that the bonding agent tends to have an attachment, so the hydrophobic bit is going to attach. No, the chemical bond between the composite layers is much more staggering compared to the bonding agent providing the attachment. Because I'm challenging the chemical bond between the composite layer rather than having a bond with the adhesive layer. Because again, coming back to the same example, that composite works best without interfaces. So there should be no arbitrary interfaces between. It should be a smooth layer, as much as smooth layer. Obviously, when you're placing a composite in a deep layer where there is a bit of infected or affected dentine left behind, and where you therapeutically need to add a resin modified glass ionomer, so that I can understand. You can place in a thin layer of resin modified and then place in a composite with the adhesive on. But generally, I do not really promote this idea of uh, adding adhesives in between composites.
Yeah. So the next question is, It's not preferable to use any liner under composites. We understand that. Even though if it's unaffected, uh, if even if it's an affected layer, not infected.
No,
If there,
yeah, let me just rephrase my sentence over here. It is preferable not to use a lining underneath composites, yes. But if there is a therapeutic reason, the paper that I'm quoting to all of you that says, the paper says that if there is a therapeutic reason, you have to use a lining. Now, what are those therapeutic reasons? Like, let's say you're drilling a cavity. Like many endodontists don't like me saying this because you have to make sure that this tooth structure should not go to an endodontist, because the endodontist is eventually going to open up the pulp, and then you end up having the root canal, and that's the open heart surgery, and then that's the end game. For me, that's the end game. But as an operative dentist, and perhaps someone who is looking more into adhesion, I would want to rely on my dentine structure as much as possible. Obviously, if it's a completely dilapidated dentine structure, completely infected dentine structure, that's going to go out of the picture. But let's say you've got something between infected and affected, right? You have, okay, you have either affected or you have infected. Even if you are leaving behind the infected dentine structure, that's based on your clinical judgment. How much are you leaving behind? For that, I would be very comfortable using a razor modified glass ionomer lining. I'm not, again, a huge fan of using calcium hydroxide. Razor modified does a good job under the composites, in my opinion. So, placing in a razor modified under in a therapeutic condition is still warranted. But when I'm looking at a healthy dentine structure, especially the particular pictures that I just showed you, the healthy dentine structure does not warrant a lining.
yeah. So the next question is, if the brownish dark surface isn't soft anymore of affected dentine, should we leave it without removal or not?
Okay. uh, I'll answer this. It's a two-pronged answer I will give you. If the structure, if the structure that you are, let's say you're leaving behind the structure, if the structure that you are leaving is hard, like you mentioned, let's say if it's very hard, and let's say if you can slightly drill it out also without compromising the tooth structure. My first priority when I'm doing a composite bonding is how much have I retained the tooth structure? How much am I sacrificing the tooth structure? So let's say I'm not a big fan of leaving behind anything while I'm bonding, but like that's the natural thing. That's what really actually happens in reality, because the dentine is not perfect. So if there is a brownish structure that is extremely hard, I will still try to be a little bit more aggressive and try to take that out and see if I can go beyond that brownish line and see without damaging the tooth structure. But again, if there is a decision that you need to make in between retaining the tooth structure or not, then of course I will be more than happy to leave behind a very strong, hard, glassy dentine behind, and I would prefer to use a total etch technique onto that brownish layer so that a bit of dentine is demineralized in that section also.
Yeah. So the next question is, how to prevent dentine over drying?
Ah, well, that's it was a simple, straightforward answer. Where first of all, you should never bond onto a dry dentine. Believe me, creates a lot of problems. The collapse of the collagen structure and blah 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 and all that. But to keep it wet, so okay, so when you have washed away the acid etchant, you're using your triple syringe onto the tooth structure. So you're going to dry the tooth structure in a very gentle manner and with breaks, like psst, psst, something like that, rather than psst, Normally students do that, like, they want to, like, they're in a bit of hurry, there's another patient coming in, let's just do it quickly and get rid of the patient as soon as possible. But composite requires a lot of dedication. I've just spoken very basic fundamental steps in this lecture. So if you follow those structure, uh, just following those structure will eventually, because a lot of clinical success resides within the hands of the clinician. So if you keep the dentine, if you dry the dentine with breaks, and not just completely buzz off your triple syringe on top, do it with a gentle stream of air, and make sure, like I mentioned previously, that your dentine structure appears a little bit of glistening, bright. So that shows that the dentine on top is has a little bit of moisture. So the dentine, when it has a little bit of moisture with a little brightness on top, and then when you apply the bonding agent, the penetration of the bonding agent is more. I'm
Uh,
sorry, was
the
I
other
clear?
Yeah, there was a connection issue. Uh, Difference between bulk flow and full body composite. Can you enlighten?
I'm sorry.
Difference between bulk flow and full body composite.
Well, I think you're talking about the bulk flow and the conventional packable composite. Is I think primarily the difference in the bulk flow is for the filler content. The filler content. I'm just doing the basics here. The filler content is lesser, so the bulk flow will have a little bit of flowable properties to it. The bulk flow, because of being a flowable, it has the ability to be placed onto the dentine structure at a thickness of close to 4 millimeters. It can go up to 4 meters. That is the reason why we introduced the co-blend technique. The other one, the packable one, that you have to do it in the incremental lining, 1 to 2 millimeters of composite, you are incrementally packing onto it. But with bulk flow, you can just place it with one single bulk onto it. But I would really encourage the students to try on the co-blend technique, where what they do is that they place the bonding agent, and then they place the bulk first layer on top, and then mix it together and then cure it together. So the bulk flow is placed at a much higher thickness as compared to the packable conventional.
Yeah, so the next question is, can the seventh and eighth generation technique bonding system be used in all clinical techniques?
Yeah, that's a bit of controversial. Uh, uh, I mean, like I said, I mean, like, I will not sit here and really put a pressure on these minds over here to think the way I'm thinking, that there are certain bonding agents that I would prefer. I would rather say that every bonding agent, every adhesive that you're using, if it is done with a proper technique and you followed the fundamentals, it is fine and it will work out well. But if you ask me, as a personal preference, I would prefer the total etch and rinse still, and I would use the self etch with the selective etch technique.
Okay.
Universal,
We have
I'm
no,
still a little bit wary about universal at the moment. I'm sorry. Yeah.
we have many questions regarding research. We'll ping you for that afterwards.
Yeah,
If
yeah,
you are,
anytime. Of course, of course, of course. Research is. I mean, I was under the. I was speaking to one of the dental colleges in Karachi for bringing up research. So I've given them a suggestion to start a module within the undergraduate, because that's what we are doing here at our university. What we are doing is that in the third year, the undergraduate, as a compulsory module, he works with one of the supervisors, and well, in our case, it's mandatory for us to publish through that project. But that is something that needs to come up in our curriculum in our universities, that the undergraduate students now need to take part in research more, rather than they are thinking that this is just a postgraduate phenomena. No, 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 no. The undergraduates now need to start reading more papers, by the way. They need to read more, and they need to read more and more of these review papers, like specifically in bonding and adhesion. There are a lot of review papers that are coming in, and now downloading papers is now not an issue, I presume, because it's accessible to everyone now. So the undergrads really need to develop a research mind now, rather than just being hardcore clinicians.
As we have reached the time limit, thank you so much, sir, for your time. We are very, very
Thank you.
grateful.
Thank you, Dr. Nayab. I hope it was a fruitful thing. And like I said, like you mentioned me that there were a lot of students involved, so I did try to keep the presentation uh, that is more digestible for the students. I'm more than happy to take any suggestions even later on. If there are students who have questions, I would rather put my email in the chat, my personal email. You can either put those questions over there, or if you have any research projects, anything that comes up with your in your mind, I'm more than happy to answer.
Yeah, we are having a research series. We'll ping you for that.
Absolutely. Thank you very much. Thank you very much.
So to all the participants, we are having a quiz. After 2 days, you can uh, apply for the quiz on website. So after attempting the quiz, if you are cleared, we will issue you a certificate through your email. Thank you so much for your time, Dr. Umar.
Thank you very much. Have a nice weekend, all of you. Thank you. Bye bye.